I'm Dr. Aaron Anderson. I am a upper extremity fellowship trained surgeon at Lancashire Bone and Joint Institute. Basically, I treat anything in the arm, so shoulder, elbow, hand, and wrist. Today is basically just going to give you an overview of what we do, specifically in this section looking at the elbow, wrist, and hand, common injuries that I see. I have a couple case examples that we'll also go over. And if you have any questions, you guys can feel free to raise your hand and I will answer them as we go along. So just an overview. I thought about when we talk about these things, basically the most common things that I see, and also I like giving talks that give more issues that happen and common things that happen that can go wrong. And so that way we can prevent these things from going wrong to kind of give better treatment in the future. So basically, overview, we're going to do biceps tendon ruptures, cubital tunnel syndrome, radial tunnel syndrome, carpal tunnel syndrome, distal humerus fractures, both bone forearm fractures, distal radius fractures, carpal injury, and fingertip injury. Don't worry, this will not be like 5 hours long, okay? Each one of these topics probably could be, you know, at least an hour in itself, but we're going to be giving kind of just a brief overview of them, so it's not going to be too long. Keep you guys awake. So basically, biceps tendon rupture is a very common thing we see in the work comp world because this is from a forced extension of the arm. Someone goes to pick up something, they feel a pop. This is also probably one of the most litigated and missed things we see in orthopedics because it's often missed. And the reason why is you have multiple muscles that have your arm bend up. You have your biceps, which everyone talks about, but you also have your brachialis muscle. So someone can rupture their biceps muscle completely and still bend their arm. So generally what it is, people see it in the ER, they diagnose it as a strain, it's sent out, forgotten about, the person doesn't get better, they still have weakness months later and complaints of pain and loss of function, and then now it's too late. So it's often missed, like I said. You really want to do this urgently because the biceps muscle, when it detaches, tends to retract proximally. So it's like kind of you go to pull and it just twings up back and it can retract up to 10 centimeters. And muscles don't like to be shortened for extended periods of time. So if your muscle is shortened, it's hard to get it re-lengthened. And that's why you have to get it done. Now, urgency, it's not an emergency, it's more of an urgency. Usually within a month. What I really liked is to get them done within 2 weeks of injury, but within a month usually is okay. Once you start getting past a month, you start getting into more complex issues and difficulties. The biggest thing you see, so basically the most common thing someone presents, they try to lift something, they feel a pop, they develop bruising, swelling around their elbow. X-rays are usually negative. And the biggest thing you see is decreased strength with supination. So they'll be able to flex, but they can't turn. And that's what happens. So they think that they're fine because they can flex their arm. Months go by, and then when they're trying to turn something at work, they find they just fatigue very easily, and that's the issue. So with biceps tendon rupture, what we do obviously is repair it. Now the question is, do you have to repair them? Well, in this group of people in the workman's compensation area, the answer is yes, because these are all laborers who are working and usually heavy laborers. However, because you can move your arm still after it, if you're older and you are a low demand person, you don't necessarily have to fix them. And that's the first thing I tell every patient when they see me. It doesn't have to be fixed. It's not cancer. It's not going to kill you. You can definitely live with it. What does it mean to live with it? Well, you get about a 40% loss of flexion strength permanently and about a 50 or so % loss of supination strength. Now, you know, if you're not doing a lot, that may not matter to lose 50% of your strength. But for someone that's a laborer that's doing it, they usually do it. So basically there's two ways to do it. You can either reinsert it with one incision versus a 2 incision technique. What I do is kind of a minimally invasive approach that gives a little quicker return to work and lower complication rate of a 1 incision technique. What you see up there on the screen is a basically intraoperative photo of one of my patients. So this is called a whip stitch. So these are fiber wire stitches that you see here. They're very strong Kevlar coated stitches that are whip stitched around. This is the tendon, this is the wound, this is their arm, their head's to the right. And then basically we take this down and we repair it with that button that you saw on the previous slide. This is one of the it probably costs, I don't know what it costs, probably costs like a cent to make, you know, and they sell it for like $300 or something. But it's actually an ingenious idea. That button is a 2-hole eyelet that the stitches go through. So it basically flips through down into the bone, straight up and down, goes through and then flips and then holds the tendon into the bone. So it's actually a very smart innovation, but very overpriced. So this is what it looks like intraoperatively and afterwards. So basically after they have the surgery, we put them in a splint, and then return to work unrestricted is about 12 to 14 weeks after surgery. Cubital tunnel syndrome is probably one of the also very common things I see. It's basically injury to the ulnar nerve at the elbow. It causes numbness and tingling in the ulnar digits, which is your small finger and half of your ring finger. Symptoms usually compose of numbness, cramping, and weakness, and also pain with activity. Treatment, what we try to at first is from nighttime splinting. You try to keep your arm straight, avoid resting the elbow on the inside of hard surfaces, activity modification, and then if that doesn't work, basically surgery. We do here a minimally invasive approach with an in situ decompression, which is pretty much what most of the industry of hand and upper extremity surgeons has gone to now. We used to do transpositions. Actually, I did just as early as maybe 8 years ago. We transposed everybody, but now we found that to be rarely necessary. So here's an example of a patient intraoperatively. That's my incision. That's my initials there. What you see in the red is what the old incision used to be. So you can imagine if you cut someone that much compared to what you see currently, the recovery is a lot faster now. So the recovery for this used to be months and months. Now, pretty much most people are back to work within 6 to 8 weeks after the surgery. And in the non-compensation world, actually probably about 2 to 4 weeks. That's just another example of it. So radial tunnel syndrome. This is one of my biggest pet peeves. It's very, very commonly missed. And a lot of, there are still, it's not so much anymore, but a lot of people that don't even believe in its existence in the country. So basically, radial tunnel syndrome is often confused with lateral epicondylitis, which we actually very commonly see in the workman's compensation world. So it's a repetitive use injury, or you can have it from direct trauma. But basically, it's compression of the radial nerve. And the difference is, and the X you see on the screen is where tennis elbow typically hurts. Radial tunnel tends to hurt about 2 to 3 centimeters distal to that over the brachialis muscle. Symptoms compose of pain, cramping, weakness, and like I said, it's often confused with lateral epicondylitis. It's important to get the difference. I had one it was actually a workman's comp patient who was in the system probably 4 years, transferred back and forth, different people. She ended up having like shoulder surgery, all these surgeries, and she had the same complaint that she had from day one, which actually I looked back and saw her notes was documented from day one, and it's actually her only complaint, which was pain in the radial tunnel area. And basically everyone wrote her off. She came to me, as a lot of these patients do, as the 18th opinion. And I saw her, we diagnosed as radial tunnel, and basically we did a radial tunnel decompression. And she, after 3 years of being out of work, went back to work unrestricted at one of the local factories. So it is a true diagnosis. It is seen, but like I said, it's often missed. So treatment, the first thing we do now, what sort
of causation would result in this?
Any kind of, it's repetitive use, because it's basically pronation, supination exercises of twisting, or direct trauma. You very commonly see it. That space is very small. So if someone gets like a hit to the elbow or into the lateral region of the arm, it can flare this up. And then what happens is a lot of times, now realize not everyone needs surgery. I would say 90% of the patients I see get better from an injection or just rest and activity modification. These are only the severe ones that just don't. They get that scar tissue build up there and it just doesn't get better. So what I'm showing here is an example, and this was very difficult. Previous to maybe about, it's been now maybe 3 years since we've been doing this, since the advent of the ultrasound, we haven't been able to adequately do a diagnostic therapeutic injection for radial tunnel because you couldn't see it. Arms are big and it's hard to see if you're around the nerve. Now that we have ultrasound in office, when we do these injections, I found this to be extremely accurate for determining whether a person has radial tunnel and also their surgical success. Because in general, the success from injection correlates very, very well with success with surgery. So if they're not getting better from an injection, assuming you know the injection's in the right spot, they're not going to get better from surgery. It is probably not radial tunnel. So, or they're malingering or there's other issues, who knows. So this is an example of an actual patient ultrasound intra from my office. And you can see the needles up there on the top. You can see it's a straight white line. The radius on the left, almost on the right. And actually, I remember I did these slides to show you. There you go. That's a superficial thing of the supinator muscle. This is the deep belly of the supinator muscle. That's where the nerve is, okay? That's the radius, and then that's where the needle is. And so we're injecting in the tissue surrounding the nerve. And you can see as the radius turns back and forth, that deep belly of the supinator muscle rubs against the superficial belly, and you can see that little yellow nerve just gets rolled in between there. There's not a lot of space. So if you have a repetitive use, you can see how that nerve can just get rolled back and forth and be irritated and cause pain. Or if you have a direct trauma there that causes scarring, where that area is scarred, it's like sandpaper on that nerve, okay? So this is an example of surgical decompression. Now, like I said, probably 90% of people do not need surgery for this. But that 10% that fail this is what we end up doing. And here's an example. This is an intraoperative photo of a radial tunnel decompression. So you can see here coming down is the nerve. And this is that fascial band that goes between there. So as you spin your wrist, like back and forth, that band of tissue is rubbing against that nerve. So what you do in surgery basically is you just go and you just cut the band. It's actually a very simple surgery, okay? And by cutting that band, you decompress that nerve in that area, and patients get better very, very quickly from that. It's actually all the nerve surgeries, carpal tunnel, cubital tunnel, radial tunnel, done minimally invasively, take about, on average, like 6 to 8 weeks to get back. Now, that being said, you have to look at the type of job. That's from a regular lifting job. If you're talking about a job that someone's a factory worker where they're doing like 10,000 parts a day, they're going to take longer. So you got to look at this based on what their job is. So carpal tunnel everyone's heard about 1,000 times. Basically, trauma, repetitive use, that's numbness and tingling in the median nerve distribution for compression of the median nerve at the wrist. Treatment, you start with nighttime splinting, activity modifications, and then the same thing here. Before, we were hesitant to do injections because there's a wide variation of where the nerve runs across the wrist. And to guess that based just on anatomy, you tend to, every once in a while, hit the nerve. And while that doesn't cause any permanent damage, injecting into someone's nerve hurts a lot, and you will lose patients. And so now that we have ultrasound, it's not an issue anymore, because you can see, as everyone can clearly see where the nerve is on this picture. I mean, it is as clear as day. I'm just kidding, obviously. Okay. That's the nerve. Okay, there you go. I colored it in yellow. Our ultrasound doesn't do that right now, but that's basically where the nerve is. That's where the artery is, okay? And so you can see, it's basically like, you know, kicking a field goal. You just go right between the nerve and the artery. The blue is the tendons. And so you can actually see here, let me see if I labeled it. Yeah, there we go. That yellow is the transverse carpal ligament. And so what you see is the tendons, which are blue, swell, and from repetitive use, trauma, whatever, and they put pressure on that nerve. Now, that yellow band on the top is what it pushes against. So when the tendons swell, they push that nerve into that band, and that's what causes the symptoms. So the way you cure it, it's very simple. It's a mechanical problem. You inject it with a steroid or take anti-inflammatories to try to decrease the swelling. And then if that doesn't work, you decompress it by cutting the yellow band to make it bigger. And that's where we would do the injection, so you can see what you're doing. There's many ways to do carpal tunnel releases. This is argued in the literature left and right. I was trained with one of the original developers of the endoscopic carpal tunnel release in Syracuse, New York. And so this is kind of my preference. I like it because you're not cutting a big incision in the palm, so people tend to get back to work a little faster, which actually that's the one thing that has been shown in the literature, and have a little less pain. So this is what it looks like. This is the device. This is an AG device. And so this is actually an intraoperative photo of that's basically you make a small incision at the base of the wrist. You insert the camera there, and on the right side there you see the view of the ligament. And so when this first came out, it actually got a lot of bad reviews, and that was largely because everyone kind of jumped on board without proper training. And so there was a lot of very high complication rate. But since then, you actually can't even get that device anymore unless you've been trained properly by someone who did it. Now, I happen to be grandfathered in because I was trained by the person that invented it, but you can't get it. And so if you actually look at the new studies, compared endoscopic versus open release with trained, fellowship-trained people, the complication rate is identical. So there is no increased risk for this, but there is a decrease in decrease in time to work. And so that's an example of it being cut. So you can see on the right, you raise the blade up through that device, and you can see the ligament is opening up, widening up, and increasing the space. That's what it looks like when you're done. Okay, so move on to trauma. When did I start? So basically, distal humerus fractures. It's a common thing I see. So this is basically humerus fractured. That's pretty obvious. It's split up. What we do for this usually is open-reduction or internal fixation, which is basically you just plate it. Now, one thing that we've done here in our area differently than pretty much, I have a whole bunch of friends all across the country. We all are a tight group of hand surgeons and upper extremity surgeons. And we are very good in Northwest Indiana with blocks and pain management postoperatively. So if I talk to my friends and I show them this x-ray that I just showed you in New York, Cleveland Clinic, Mayo, Harvard, this is a 3-day hospital stay across the board. They're remitted, patients there, it stayed. And in our area, this is all done outpatient. So, and that's very unique to Indiana. And I think we have very good anesthesia here, and they're very good at blocks. And so this patient was done outpatient. Now, it's not always. Obviously, if you have an older patient or you have a patient that's sick or polytrauma or whatever, they're inpatient. But the vast majority of upper extremity fractures that we do, shoulder, elbow, hand, wrist, forearm, are all done outpatient without any length of stay in the hospital. So these are both bone forearm fractures. This is an interesting case that I saw recently, actually. So basically, this is a patient that had a fracture fixed. Obviously, they weren't born with the metal in there. And now this is like more of a lesson to be learned about what happened. So this person was there, and then they were at work, and they felt a pop when they got hit at work. Okay, they were then sent to an ER, and the X-ray was read as normal, and plated bones or whatever, and no acute fracture. So then she was sent back to work, and no other follow-up was done. She was basically sent to whatever the clinic was, and then that was it. And what they unfortunately, and the X-ray read too also said the same thing. Unfortunately, what they missed is what those two arrows see, which is clearly the plate's broken in half and it's failed, okay? But the patient had persistent pain, symptoms, back at work, complained, multiple call-offs, whatever. And I think, now obviously the initial mistake was they misread the X-ray, okay? That's obvious. However, this would have been easily cured if when the person still complained of pain and symptoms, they got a secondary evaluation. Specifically, in general, I would say if you have plates and stuff in your arm and you're still having pain, you should probably up the level to an orthopedic surgeon, because there's no orthopedic surgeon that I know in the area that would probably miss that. So it was missed, okay? So she went literally 13 months complaining of pain at work, multiple call-offs. You're crazy, because her x-rays were normal. Now what you can see here, what happened is the radius subsided. She dislocated her ulna, and she was told, which she believed, that the ulna sticking out was just swelling, and she basically was living like this until she saw me. Finally, she complained enough that they gave her an evaluation finally to an orthopedic surgeon when we got this x-ray. So obviously this is a big problem. You have someone with a dislocated DRUJ, you have a malunion of a radius with multiple shortening. So basically what we did for this is we had to reconstruct her entire arm, which we actually did outpatient as well, surprisingly. But so basically we had to shorten her ulnar bone probably about, I don't remember, it was like 3 centimeters maybe, and then reconstruct her radius, put it out to length, and then do a DRUJ reconstruction. DRUJ, for those of you who don't know, is the distal radial ulnar joint. That's the joint up here that allows your wrist to spin. Without that, you can't spin your wrist.
That's yesterday.
Yeah, so It's a big problem, but a problem that probably could have been avoided. I mean, in the end, she's probably going to do okay. But the reality is, I think the lesson to be learned here is if someone is having persistent complaints, you should probably up the evaluation to a higher level, especially someone who, when you look at, has had previous surgeries or whatnot. Now, the previous surgeries had nothing to do with compensation, but it's a higher complexity. And so, you have a new injury at work and this and that, and so this can happen. And so I think that's kind of the lesson to be learned on that one. So distal radius fractures, this is also extremely common work injury. Anyone that falls on an extended wrist, they fracture their end of the wrist. Treatment, casting, closed reduction percutaneous pinning, or open reduction internal fixation. Timing is a big thing here because people always freak out about that. You have 2 weeks to fix any fracture in general. So these things don't have to be done emergently. They certainly don't have to be done in the middle of the night unless they're open. And even then, they probably can wait till the next morning. So you have time to get proper evaluation, look at the fracture properly, and then fix it properly so it's done. Complications, arthritis, and EPL rupture is probably the 2 most common. So this is an example of casting. In general, adults, unless they're old, like 80, don't do very well with casting unless they have a very, very simple break or simple fracture. And the reason why is when you get older, your bones are brittle. When you're young, your bones are thick and they have a thick socket periosteum around it. So kids, you can reduce and they stay reduced in a cast almost always. Adult bones tend to crumble, and they tend to crumble in casts. And the reason why I say this is because it creates a lot of problems for a subspecialist when I get the relating things afterwards. So this is an example of someone who was casted, and the alignment in the cast, quite honestly, looks okay. This is completely adequate. But if you look at it, they're older. They're not that old, they're like 50, and this is what happened later in the cast after it healed. So now you have someone who's got a variance, almost protruding about 3 centimeters or so, and they have a bad radial malunion. So this been fixed initially would have been a nothing case, in and out, outpatient, and get back within 5-6 weeks, healed, back within work to a heavy job within 12 weeks. Now it's a big problem. So now this person's been out of work while it's healed for probably 10 to 12 weeks. It's healed, it's a malunion, persistent pain, increased risk of all these issues and stuff. So basically, fix them early in older people, especially if they're comminuted. And the reality is, to do that, you just have to be someone, that's why you send them to people that do a lot of upper extremity surgery, because then you know what is stable and what's not stable. This is just some intraoperative photos of what it looks like when we do fix it. So basically, you make a volar approach, incision there, and we put this plate in. That's an example of putting the plate in. That's just screws. It's the same thing as doing like your door outside and putting a little plate and screws in a wrist. And then we check the x-rays intraoperatively with C-arm. And this is an example, that is that case. So basically, in that case, we basically lengthened the radius out to re-level the joint and then plated it. But this is a lot, not only is it harder for the patient, it's also a lot more expensive. Because to do this, you're now having to do thousands of dollars of bone graft, lengthening, a lot more time off, and everything else. Where if you fix it first, early meaning within 2 weeks, they tend not to have these issues. And this is my other big pet peeve, we were just talking about this, is a perilunate dislocation. This is probably, I don't know what it is about, maybe this is nationwide, but definitely in Northwest Indiana, this is commonly missed on x-ray. And it's a bad problem to miss it because it causes permanent problems, disability. It's probably, again, one of the more commonly litigated things. This is a transcaphoid perilunate, and what I mean by that is this is dislocated. Now, if you look at that, it looks like the person has maybe a scaphoid fracture. The bones look aligned, okay? And so the ER doctor or whomever looks at this and says, okay, they got a little fracture there or whatever. We'll put them in a splint and send them out. What they don't see is they don't check the lateral closely. And what you can see on the lateral, or the side view, is this bone, this little, it's called a lunate because it looks like a moon, is sticking out the bottom there, okay? And this here, this should be in here. And that's a problem. And I'll show you why it's a problem. It's called the perilunate dislocation. And it's a problem because you have a nerve there, the nerve that's a carpal tunnel nerve that we talked about earlier. And so Oh, that's an example of showing what a normal wrist looks like on the left and how this is dislocated on the top. And same thing there. So on the left, you see a normal wrist, and on the right, you see where that lunate has popped out the bottom. And the reason why is on the left, that awesome drawing of a nerve that I did, which is, perfectly anatomic, is it shows the nerve straight, okay? That is what your nerve generally, not exactly looks like, but looks like, okay? Now you can see in the dislocated one, that's what it does. That lunate pops down right on the nerve and tense it, and that's the problem. Because now, without it being reduced, you're having tension on your nerve, and nerves don't like that. They tend to not come back or go out and run into more problems. So this is what I did for this. Basically, you just reduce it and put a screw across it, and they do fine. Well, not really, but they do okay. And then this is, I always put this at the end because this is basically my thing. Everyone freaks out about finger injuries at the end of you need all these fancy flaps and all this stuff. And I trained in Syracuse. We were a little old school there with it. Your fingers are amazing organs. They can regenerate without fancy flaps and skin grafts extremely well. There's obviously, this is why you have to go to a hand surgeon because you have to figure out which one's which. But in general, as long as the bone's not poking out or whatnot, these heal with granulation extremely well without any surgery. Most of these things I see, the ER doctor, whoever will call me and they'll be all scared, they need emergent surgery, the patients will be all scared. And in general, they heal fine. So on the left, you see that's what it looked like initially, and everyone's talking about flaps and this and that. And this is what it started to look like in the end. And eventually that nail will grow over there and everything, and it will look, pretty normal. Your fingers are amazing. This is another example of a fingertip amputation distally. And then that's what it looked like with no intervention by me at all. Of course, I'll take credit for it because I, watched them. Okay. I had them come in every couple weeks to make sure it wasn't infected. But in general, you don't have to do a lot. Now, that's not true every time. There are some times where you have to do VY advancement flaps or different types of flaps. But in general, hands do better without that. And granulation, that's what this is called, healing by secondary intention, does very, very well. Your actual, especially in the northern places, because up in Indiana, because it's cold, we get a lot of cold intolerance problems. And cold intolerance is higher if you do a flap. If you don't do a flap, the cold intolerance tends to go down. Now, sometimes you don't have a choice and you have to do flaps. But if you can get away with not, because it's a proper injury like this, and it will do better with the injury, this person will do very, very well. Even though when they first came in, it didn't look like it. They first come in, they're freaking out. I lost my finger. You got to take me to surgery emergently. And you can see later, no, you don't.